contributing writer at Those Nerdy Girls. My guest today is Dr. Sara Gorman, our fearless leader, who also wears many other hats. Sara's going to be giving you a brief update on the state of Those Nerdy Girls, and then we'll answer some of your questions about COVID-19. Sara, can you briefly introduce yourself?
Sure. Hi, everyone. Thank you for being here. My name is Sara Gorman, and most importantly, I'm executive director of Those Nerdy Girls. I also am a researcher with a background in the intersection of psychology and public health. I've studied the science of science denial and misinformation for about the past 10 plus years. And my first book, called Denying to the Grave, came out an updated edition in 2021 and really explored the psychology behind science denial. I have another book coming out from Oxford University Press in September that's all about conspiracy theories and medical mistrust. And I'm really happy to be here to talk a little bit more about the future of TNG.
Thank you, Sara. We feel really fortunate to have you at the helm. So, so let's jump in. Sara, tell us what the readers can expect from Those Nerdy Girls in 2024 and beyond.
Sure. So we had some really great successes toward the end of 2023, especially. We won a prestigious award from the Interdisciplinary Association of Population Health Sciences, or IAPHS, that we accepted in October of 2023. And this was a public engagement award. So really recognizing our talent at bringing many people into the discussion about health and science. And we also had a very successful end-of-year fundraising season. We saw a lot of our community members really rallying to help us reach and surpass our goal, for which we're extremely grateful. And this year, we have a few specific focus areas. One is that we want to work on diversifying our writer base, and hopefully through diversifying our writer base to reach a broader community out there in the world of people who have questions about health and science. We also want to formalize our training program, the kind of training that we do with new writers who come into Those Nerdy Girls, but create it as a real curriculum for different professional communities like doctors and nurses, and even for undergraduates who are interested in science writing. And we're looking at some potential funding opportunities in those areas right now. And then I would say one other area is that we want to expand our ability to consult with other organizations about communication of health and science. We already do this with some organizations, mostly nonprofits and government organizations, but we want to create a clear offering so we can provide our insights about writing and speaking about health and science to a broader range of organizations.
Does that summarize, hit all the high points for you?
I think so. And I just want to say we're so grateful to all of our supporters, especially our readers who have been following us for all these years. It really makes a big difference and really helps us understand our impact. So we really appreciate everybody's time and the attention that they give to our content. And I hope that it's really helpful.
Absolutely. The reader engagement is the number one driver for all of us. So yeah, thanks for me as well. So let's shift gears and answer some reader questions. And today we're going to be talking about COVID-19 again, which is now just one of several, focus areas within Those Nerdy Girls, but it is one that continues to be very popular in our question box. So that's the focus today. And in the future, I'd like to revisit reproductive health, because we're also getting many questions about reproductive health and women's health. So as a reminder, we don't take questions cold. So the questions we're going to be answering today came from the Nerdy Girls question box on our website. So you can submit your questions at thosenerdygirls.org. So Sara, I'll let you get started with more of a backgrounder right now on what's the state of COVID-19.
Sure. So I think a lot of you have probably seen in the news and including in some of our content that the dominant variant is this JN1 variant, which seems to be similar to a lot of the other variants in terms of symptoms, cold and flu-like symptoms. And it does seem that as new variants arise, they can sometimes be more contagious, but they're usually not more dangerous or resulting in higher rates of hospitalization and death. So that is some good news. At this point, the CDC mostly uses wastewater and hospitalization data to understand the prevalence of COVID at the moment. So these are imperfect measures for a lot of reasons, which I'm sure we cover somewhere in one of our posts. But we do get a sense of what's happening, and we have seen an uptick over the past month and a half or so in cases it does seem that as of more recently, the hospitalizations are peaking. So it might be that we could see a downturn soon, and we've kind of hit the height of the high rate of infections, but it's still higher than any time since last winter. So we are at a high point. And this has to do with a few things, especially during the holiday season. There's waning immunity because only about 18 to 19% of Americans got their most recent COVID shot this fall or winter. So people are not as protected against the illness. There's also the factor of the holidays and people traveling and going to large gatherings together, and also people staying indoors together because it's cold. So all of these things, the same things that would make you more prone to getting the flu or a cold in the winter, are there with COVID as well. And also, as I said before, JN1 is probably more contagious than other variants. But there is some good news in the COVID research front. So one is that we have more data confirming that the new COVID vaccine that came out in September is effective at reducing hospitalizations. So it's about 70% effective. And we also see that that vaccines might actually be something that prevent long COVID. So staying up to date, the more up to date you are, the more protected you are against long COVID. And there's also some real world efficacy studies showing the efficacy of the vaccine in children as well. So some good news there, although we are experiencing a little bit of a peak here.
Yep. Thanks for that broad overview, Sarah. I'm going to drop a couple of links for people to learn more about this, including some news roundups and a great post from YLE, your local epidemiologist. Okay, that helps set the stage a lot. So let's move on to some reader questions.
Sure. So I'll ask you the next one. This is basically, a lot of these questions are about how bad it is to get COVID multiple times. So one person, Ruth from Santa Rosa, California, says, what is happening to our immune systems with these repeat COVID infections? Rebecca from Chicago says, can you please share any data, studies, et cetera, on reinfection outcomes on kids aged 5 to 10? And then Mary from Philadelphia asks, everything I have read paints a very promising picture of possible implications for people getting infected multiple times. Part of a larger question expressing frustration at lack of precautions for most people. So all of these do roll up into sort of that question about reinfection and what are the harms of being reinfected.
Mm-hmm. Well, the honest answer, like a lot of things, is we don't really know, as much as we'd like to know about this yet. The picture is a little bit murky because we're seeing different results across different studies. And it seems that the toll of reinfection depends a lot on the population that you're talking about. That's part of why we're seeing different results across different studies. So there is no one size fits all answer, unfortunately. But in general, it seems that reinfection cases tend to be less severe. So this is good news. And this makes sense because your immune systems are getting educated once you're infected. And so you kind of know what to do when you're infected again. But there are important exceptions. So for people who are, certain populations are actually still at a high risk of getting a severe disease when they're reinfected, and possibly even more severe. And this includes people who are older, immunocompromised, or had a very severe first infection. So, like I said, not a one size fits all answer. Just to, so when I've read a couple of expert interviews on this topic, and one of the analogies that's come up a couple of times is Russian roulette. So basically, the more times you play the game, the more likely you are to get unlucky and be hit with something severe. So even if your odds of a severe infection are really low in general, like most kids, for example, if you play enough times, your overall odds increase. It may not be that the risk per infection is higher, but your overall risk of having, whether it's severe disease, whether it's long COVID, it just makes sense that the more times you take that chance, the more likely it is to happen overall, even if each chance is the same. Does that make sense?
Yeah.
But once again, people who are at greater risk of severe disease, they're shouldering, a larger proportion of the overall risk because they're at higher risk each time, and the cumulative impact may be higher in them as well. So just to give you a couple of details from studies, one study you may have heard of that got a lot of attention in late 2022 was quite alarming because it found that reinfections increased the risk of death by 117%, increased the risk of hospitalization by 232%, and increased the risk of having at least one long-term impact by 232%. So, but this study notably was done in the Veterans Affairs National Healthcare Database, which is mostly older men, many of whom had risk factors for severe disease. So that study, made a lot of news and was one of the reasons that people, may have heard that reinfection is something to be, avoided at all costs. But by contrast, a less alarming study came out in early 2023, and this was a review study or a meta-analysis that looked across studies. So they looked across 19 studies that overall included over 34,000 reinfection cases. And they found that compared with the initial infection, reinfection cases were 7 times more likely to be mild, and that the risk of severe illness was reduced by 86%. So you can see why it's a bit confusing. It depends a lot on the population that you're talking about. Now, someone asked about kids. Unfortunately, there are very limited data on kids. I did find one study that looked at children and teens between 2020 and 2022. They reported that the proportion of severe clinical disease dropped from 1.4% in the initial infections to 0.3% in reinfections. So that was encouraging to see, but I wouldn't be surprised if you look at high-risk populations of children if you would see a different story. And I can drop a couple of links on the reinfection landscape into our chat here before we move on to the next question.
I think it can be confusing because I've seen polar opposite answers to that in the news.
Totally.
Right. So
yes.
Yeah, it makes it less severe or it makes it more severe. So it's a lot to sort of wrap your head around. Yeah.
But the confusion makes sense, like I said, if you understand that different populations have a different risk profile, both for initial disease and for the toll of multiple infections.
Right.
So Sarah, let's get into some vaccine questions. We have a number of those here. Here's one from Anne in Westchester. She asked, not so much a question, but a suggestion. When you say most recent COVID vaccine, it would be helpful to articulate a time frame. I knew I'd boosted recently, but I wasn't sure if that was the most recent, and it took some Googling to figure it out. So there's definitely some confusing language around what it means to be up to date. Another question, how long after a bivalent vaccine dose is it okay to get the new COVID vaccine? This is Deborah from New Jersey. And then finally, I forgot to write down who this is from, but here's a question. I'm 29 years old and I've had COVID 5 times now. I've had at least 4 Moderna vaccines. What should I do? No one I know has had COVID this much, and I don't know why I'm so susceptible or why my immune system is so weak. Should I get a different COVID booster?
Well, first of all, my heart goes out to the person who has had COVID 5 times. I mean, aside from it being uncomfortable and unpleasant, it's also a huge disruption to your life. And so to have it that many times is very frustrating. And we do have people on our Nerdy Girl team who are on their 4th or 5th infection. It does happen. But I want to start with the initial questions about the vaccine. So the most recent vaccine, that when we talk about the most recent vaccine, we mean the mRNA, monovalent mRNA vaccine that came out in September of 2023 for this season. And there, since that came out, there aren't any other COVID vaccines in circulation. So if you go to your pharmacy and ask for a COVID vaccine, you will get that vaccine. Monovalent means it just contains one component. So the bivalent ones contain multiple components, different, the original strain, for example, and an Omicron strain. But this is just for the XBB.1.5 variant. And it's still effective even with the new variants. But I think if you do, for some reason, if you did get a bivalent vaccine, the recommendation is to wait 2 months before you get another booster. And I will sort of catch myself saying booster, which is kind of out of vogue now. We're not really using that term anymore because we're looking at a shot that might be annual, and we don't call it the flu booster. It's just a different shot every year that's available. So it's just the flu vaccine. So we're trying to shift to that language. Yeah, go ahead.
Can I jump in on this one? Because I live in Canada, and there are slightly different recommendations here. Canada's always been more pro spacing your shots farther apart because of like a potentially better immune response when you space them. But it is a trade-off between what you potential exposure and infection while you're waiting. So I believe the Canadian recommendation is to wait 6 months if you had a dose previously.
Wow. Okay. Yeah, I think it's been difficult. A lot of people were asking the question initially of when should I get it if I had COVID recently.
Mm-hmm.
And it was difficult to say in the fall months a little bit, because if you just had it, you could wait 3 months, but then you might get COVID because
Right.
the rates were increasing.
Yeah.
So it's a bit of a nuanced discussion to
Mm-hmm.
decide when somebody should get the new shot. So
Yeah.
it
I
can be
think we talked about this
complicated.
in the last live, so you
Yeah.
can check out our website for
You
that.
can check that out. And then I was going to say, I mean, Chana already covered this, the fact that the data are really mixed about whether it's more dangerous to be reinfected. And you cited that study, which I think is the one that most people look at when they say that reinfection is ups your risk of all kinds of bad outcomes.
Mm-hmm.
But I mean, I think if you're being infected that many times, it's probably not. I mean, there can be an immune system problem, but it probably has more to do, honestly, with luck and exposure. That you may have just been unlucky to have more exposures, or maybe you work in a field where there's more potential for exposures, or you do an activity where there's more opportunity for exposure. And I know people don't necessarily want to hear this, but the best way to prevent getting it again is just to mask and vaccinate, and when there's a surge, especially to mask and not go to large gatherings. But beyond that, we don't really know what makes some people a little bit more susceptible than others. There was sort of a piece of that question, I think, about the different vaccines. And I think this may have been discussed a little bit at the last live too, or
Mm-hmm.
one of the previous ones. There is maybe some benefit from trying a different COVID vaccine, but it's probably not that significant.
Mm-hmm.
So that's really all we have to offer on that one.
All right, I can drop some links on this. Yeah, I know it's frustrating when there's not really a black and white explanation, but that's we need to get comfortable with that.
Yeah, and obviously, over time, it may become clearer what, it's
Mm-hmm.
also the same question comes up about there are still people who've never had it, and how is
Yeah.
that possible? And
Mm-hmm.
I'm not sure we really know why.
Mm-hmm.
So,
I mean, I will say that in my circle of friends and family, the people who haven't got it are the people who have the fewest exposures, like my dad and stepmom who live on an island and, are and when they do come to the mainland to visit, they're very cautious. And like
right.
all of grandparents on both sides haven't gotten it. And it's, I think, a combination of very low exposure plus taking precautions whenever you do have an exposure. And of course, they're up to date on their vaccines.
Yeah. Yeah. Behavior is a big part of this for sure.
Yeah. Yeah.
So question for you,
Mm-hmm.
does a negative rapid antigen test mean I'm not contagious?
All right. Do you have some specific reader questions here?
Yes, sorry. Okay. Nancy from East Aurora, New York. I'm so confused about the assumption that if you test negative for COVID, it is safe to attend family gatherings or public events. But you may be most infectious 2 days before you have symptoms. So if I tested negative on a Monday and attend a fitness class and then tested positive on Tuesday, did I unknowingly expose others in my class? Is there a false sense of protection when testing negative before symptoms appear, when you could be infectious and infecting others unknowingly?
Mm-hmm.
Do you want to address that, or should I ask the other ones? There's two more.
Why don't you pose the other
Okay.
two as well? Yeah.
Karen from Madison asks, if I've tested negative twice for COVID over the past 4 days and still feel like I have COVID, tired, achy, cough, headache, could it be that the viral load isn't big enough to register as positive? In which case, am I contagious as long as I have symptoms, or does a small viral load equate to not contagious?
Mm-hmm.
And then finally, Betsy from San Jose. My daughter tested negative after just 5 days from her first positive test. Is this normal for the new strain?
Okay. Yeah. So a lot of questions about contagiousness and how do we know if you're contagious? So let me just back up and say that in general, whether or not you're contagious is determined by several factors at once. One is, what are your symptoms? Second is, where are you on your timeline, like both since exposure and since you got infected, and the rapid test results. So those all really should be considered together to think about your level of contagion. So none of those alone is really going to be a perfect predictor. So rapid tests, as someone suggested, it's great to see that there's a public understanding of these tests now, that when you see a bright line, that means you have a lot of virus on the swab. And that swab is looking for actual viral protein. And so throughout the pandemic, these rapid tests have been viewed as one of our best proxies for contagiousness. They're actually far better than PCR, which is too sensitive. So you can be PCR positive for several weeks, even though your contagiousness, ended within the first week. So they're viewed as the best, test of contagiousness, short of doing a lab experiment where what you would do is take the swab and try and grow virus in the lab. And that's that's the gold standard. It's just not something that you can scale and do at home, obviously. So I think a lot of researchers view it as a really good proxy, but as an imperfect proxy. So in general, if you have a positive swab, it means there's a bunch of virus in your nose, right? Assuming you're swabbing your nose. And if you don't, then there's not a lot on the swab. But that doesn't mean that now the imperfection comes in the fact that contagiousness is not necessarily just about how much virus you have, in your nose on that one swab. It's about how much virus do you have, in your respiratory tract that you're exhaling onto people. And so you're not really sampling, in the perfect place, and nor are you sampling comprehensively, which is why a negative test can maybe be misleading and can't pick up all of the virus that's relevant to your contagiousness. So, yeah, I mean, I guess the short answer is they're a pretty good proxy, but they're far from perfect. And they can make mistakes in both directions, and it depends on where you are in your time course. So early on in your infection, they tend to be not sensitive enough, as one of the questions alluded to, because you can be contagious before the virus sort of explodes in your nose. And there's some evidence that maybe, virus is taking off in other parts of your bodies first before it's taking off in your nose swab. And so a negative result early on is not absolutely reassuring. It just may be that, you still have enough virus elsewhere to infect other people, but not on that swab. So you're absolutely right that it's not a total green light to have a negative swab early on, following an exposure, because you might be sort of at the tipping point and be positive the next day, but still contagious today. But I would say, in terms of, testing before a gathering, it's a probability thing, right? It stacks the odds in your favor of being, a safe attendee if you have a negative test. It doesn't guarantee it, but it doesn't mean it's not worth doing. It's just, if you have a negative test, you're less likely to be contagious than someone who didn't have a negative test. Does that make sense? Yep. So it's kind of a useful tool, but not a guarantee in terms of that. And then on the other side, when we're talking about, clearing the virus, we don't really understand the relationship perfectly here, but it may be that rapid tests are possibly a little bit too sensitive, not as extreme as PCR, but we commonly see people positive for 8 to 10 days. That's not unusual, but yet we know that it was one study that said 90% of spread happens before day 5. So, okay, well, how do we reconcile those two things? People are definitely most contagious in the first 5 days, and there's still some spread, but much less of it after that, which is why we have this, the recommendations we do right now of isolating 5 days and masking 5 days after that. So again, it's kind of it's a probability thing where someone who's rapid test negative from day 5, multiple repeated times is way less likely to be contagious than someone who is still positive for multiple days to day 10. But we still don't know for sure how contagious that person is on day 10 if they have this super faint positive. We just don't know yet. So it's kind of an indicator. It's just not, we shouldn't view it as perfectly. So just to be specifically answering that question about my daughter tested negative after 5 days. I want to note there that the recommendation is to test negative twice, 48 hours apart. And that's kind of what has been used in these called test to exit programs, where once you've cleared that bar, you're considered safe. So it's not unusual to have negative and then positive again. So I would advise all of you to test twice, look for 2 negatives before you're in the clear. And then circling back to the question about symptoms, again, symptoms are part of the equation. When you read CDC guidance, it says that if everyone should isolate for 5 days. But if you still have certain symptoms like fever and your symptoms are not improving, you should still continue to isolate up to 10 days. Likewise, people who have very severe disease who are immunocompromised are also recommended to isolate for a full 10 days. So symptoms, again, they're part of the equation, but they don't tell the whole story. So again, I can drop in the CDC guidance, but it depends what specific symptoms you have and whether they're improving. Some people who have long COVID, it doesn't mean that they're contagious for, a year if they're feeling fatigue for a year. So it's more nuanced than, symptoms equals contagious, but it is a factor that influences the probability.
Yeah, I think when I had it, I tested positive for like 11 or 12 days, and I felt fine. But, it was this whole thing about, should I go out? Should I stay until it's negative? It's not easy to find guidance on it either. So
yeah, it's absolutely a very tricky one. And of course, it depends also on, on the situation. Are you exposing someone who's vulnerable? Are you exposing a ton of people? So it's that you're taking a small risk, and so you just have to be thoughtful about doing that calculus. We have 4 minutes left here.
Okay, so can you tell me about whether I can use my expired antigen test kit?
Okay, yeah. That's when that was really fascinating for me to learn about. I wrote a post about this last year. Well, first of all, if your test is expired, the first thing I would recommend that you do is go look at the FDA website to see whether or not the expiration date has been extended further, because sometimes there's multiple rounds of extensions. And what's going on here is that they could initially only, approve tests for an amount they can only approve them if they've actually waited that long and really tested if the test still works. And so the longer we get from these tests being issued, the more we can expect to see, continued extensions based on now the test has been sitting in a lab for this period and we revalidated it after it's been sitting, on a shelf. So first I would check if the expiration date has been updated at all. And then second, it becomes a little bit kind of squishier after that, because one expert interview I read was like, well, if it's a little bit after the expiration date, I wouldn't worry about it. But if it's a lot after the expiration date, I would worry about it. So I kind of think about how you might think about certain food expiration dates there, or like some can in your cupboard. Well, if it's like, it was 2 years plus 1 month versus 2 years and, 0 months, it's not a huge deal. But yeah, so I don't really have a good answer for 3 months. For me, 3 months is kind of like on the borderline of, well, it's more than just a tiny bit past the expiration date, but it's not a year past the expiration date. So personally, I would probably still use it, but I would maybe test twice or something and be super, what's the word? Take a close look, and obviously the control line is a good indicator as well, whether the test is doing what it's supposed to do. So unofficially, I would probably still do it, but I understand, probably technically that would not be the official guidance. Do I have anything else on that? Yeah, I mean, it's not like there's this magic thing that happens after a certain point of time, right? It's very much this gradual thing. And the expiration sets that we have are really just based on how long they've been tested for. So that brings us to 1029. Wow, we did it. So just to wrap up, I want to say that I encourage you to join the Nerdy Girls newsletter on Substack. That's at thosenerdygirls.substack.com. And I want to thank you for joining us. I hope you'll come catch us on social, catch us on Substack, and send your questions to thosenerdygirls.org on our website, where we have archives of all of our lives and all of our questions and videos. So there's lots of great content. Anything you want to say, Sarah, in closing?
No, just thank you again for being with us and for being interested in our content. And I hope that we've been able to answer some of your questions.
All right. Bye, all. Take care.
Bye.